Well, welcome everybody to this April session on our, it's actually the closing health research seminar for our first year of this iteration. The health research seminar series has been running since September last year, and we've been really excited about it as an opportunity to bring together and profile some of the exciting work that's happening at UNBC. There's a whole array of health-related research happening here and lots of different types, as many of you have come to see, particularly those that have been doing research methods courses. You've been able to see so many different approaches to doing research, so many different methods, so many ways of understanding the world, and also so many ways about getting excited about building new knowledge and putting it into action. So today is not going to be any exception. And there's such a group of us that have been able to bring this into fruition. Here are some of the groups that are listed here. In particular, we really benefit from the fact that we have a health research institute here at UNBC. Rachel Wells is the director of that. And so as we come to the end of our first year, we're already looking ahead to next semester. And we're really delighted that we've got lined up already. We started this year of our health research seminar series with a panel on Indigenous health. And we're really delighted that Judy Thompson is going to be willing to be part of another session in September. So we need to absolutely confirm the dates. It's possible it might be a week later, but we're aiming for that first week of early in semester to be kicking off the series again. So you will be updated, and those of you that are changing classes or courses, we hope that you'll also stay involved as well as being able to take this as part of what you're studying. So we're looking forward to another exciting series. We're also really always open to suggestions. So last session we had the exciting student Pecha Kucha session, which was a great hit. And we're always, if there's somebody on campus you'd like to hear from, or there's suggestions for things that you'd like to see, we're really trying to make this a seminar series that brings to life things that work for people on campus. So yeah, another really important announcement. I mentioned that the Health Research Institute, Rachel is here. I often get Rachel to wave her hand. She's very knowledgeable, very helpful about all things health research at UNBC. And she and the Leadership Council, of which I'm a member, we will be looking forward to our AGM. I really encourage students, if you're still on campus, to come and be part of this discussion. If you've enjoyed the seminar series, this is a way to actually have a chance to meet people, to learn more about how health research works, to find out about how the Health Research Institute's evolving, and to learn a little bit about, we all know that universities want to foster interesting research, but we're an institute that really is trying to figure out, okay, how do we actually do that? And the more people we have involved with that, the better. So feel involved, students are always welcome, and so is anybody else across campus. So that's going to be at the Gathering Space on April the 20th. And Rachel and the HRI is easy to find on the website, and here is the details and contacts if you ever need to have it. So that's the backdrop that we like to just reframe each of our sessions. We do have people online, and I'm not sure quite how many, but we know that the online, these sessions are recorded, made available so that people online can watch, some people that can't attend. And we usually have quite a few listeners online who are tuning in and benefiting from this. So welcome those of you that are present. We have your volume turned down so that it doesn't interfere with the speakers, but and so you won't be able to pipe up. But it is also good to keep your mic muted, your microphone muted. So that we don't hear any feedback coming through. So as a backdrop, we said we're really delighted to profile a range of health research at UNBC, and today we're really excited about having Sheona Mitchell-Foster as the speaker today. Sheona is she's an assistant professor in the Northern Medical Program, and she's with the UBC's Department of Obstetrics and Gynecology. But she's also juggling both being a clinician and a researcher, which is quite a juggle. as somebody who started as a clinician and moved into research, I'm always really in a lot of admiration for people who are able to do that juggle. But it also really brings to life the kind of exciting work that you're going to hear about from Sheona. She's really actively involved as an obstetrician and somebody that works in ONG, obstetrics and gynecology. She is able to really bring women's voices into the work that she does and also the communities that she works with. So that work not only applies in northern BC, but also internationally, which is really neat, and recognizing that there is overlaps and synergies between what's happening in different parts of the planet and what's happening here, and how those conversations can be fueled in different places. I'm somebody who really admires community-based research, and I particularly admire that Sheona is able to bring that perspective into what she's doing in this kind of research. And she is a great example of somebody who's been able to benefit from some of the infrastructure that the Health Research Institute has provided in being able to kind of create opportunities to fuel work in northern BC. So a really neat opportunity and a great closing point for our first year. I'm going to pull up Sheona's slides, and she's going to come on up and turn on her microphone. For people that haven't met me online, I didn't actually introduce myself. My name's Margot Parks, and I'm one of with a group. I'm one of the group who is with Sarah Gray and Chelsea Peltier and Shayna Dolan and Damon Candola and Rachel are the crew that pull this session together. So there we go. I think we can put you up like that, and then we make it. Oh, now you're all set, and you can step into the limelight there.
Excellent. Thanks so much, Margot.
Thanks, Sheona.
Margot didn't mention that part of the reason I actually was allowed to move to northern BC is that Margot convinced my partner that it was a good idea. So I'm grateful to Margot. Yeah. Part of the story. So I'm going to be talking about cervical cancer and take you through some of the work that I get to be part of, both globally and then in the north. I would like to start by acknowledging that we meet today on the unceded territories of the Lheidli-T'enneh. And the work that I'm going to tell you about and share with you today is not work that I do. It's work that a team does and a really extensive network of people do. And we do our work on traditional territories of the Lheidli-T'enneh and Carrier, but we also work in East Africa on the land of the Buganda and the Basoga peoples. And without their welcome and without their participation, none of this work is at all possible. I don't have any financial disclosures. But cervical cancer really pisses me off, and I'm really passionate about getting rid of it globally. So I am unquestionably biased when I talk about cervical cancer, so keep that in mind. What I'm going to start with is talk a bit about the global picture of cervical cancer and talk about what screening options we have and what the difference is when we look at screening in a low resource setting, for example, like sub-Saharan Africa, compared to when we try to target under-screened women in a high resource setting like Canada. I'm specifically going to talk a lot about the Aspire project, which is in Uganda, in both an urban and rural setting. And then I'm going to talk about Cervix Check North, which is a really exciting project that is targeting Indigenous women in the North. But I want to start with why the story of HPV is really a story of optimism. So HPV causes cervical cancer. And cervical cancer is not a mystery. We know what causes it. We even have a vaccine for cancer, and we have some excellent ways of screening for it before it becomes invasive, so in a pre-cancer stages where we can treat it relatively easily. And that's amazing. So we're not talking about pancreatic cancer or ovarian cancer where we don't know, we can't quite figure out what exactly causes it or how we can catch it early. But that's not the case with cervical cancer. And as a clinician, you see hundreds, if not thousands of people during your career. But there's times when one, patient interaction changes the way that you see the world and changes the way that you approach things. And this story was one of them for me. So I was a resident training. I was doing some work in Uganda, and this woman came in. She was 28, and that was quite close to my age at the time. She had 4 kids, so that's what the G5 means. She's had 5 pregnancies, 1 miscarriage, and 4 deliveries. The youngest was just over a year, was still breastfeeding. And she came in and she was hemorrhaging. She was hemorrhaging and hemorrhaging and hemorrhaging. And everybody around me seemed to know exactly what was happening. And I didn't. And her hemoglobin, so normal hemoglobin, kind of how many red blood cells you have, is over 115, and hers was 33. So she had lost kind of the majority of her blood volume. And she was found to have this advanced cervical cancer. And remember, we have a vaccine, we know how to screen for it. This is completely preventable. And the only option for treatment at this advanced stage was radiation. But there's only one radiation machine in Uganda, and it was broken. So the only thing that we could really do is try to rustle up a few units of blood for her. But ultimately, she died fairly soon after that. And this is a story that I carry with me. A young woman, and the impact that had on her children, her family, her community is really significant. Now, in cervical cancer, there's been a massive paradigm shift over the past decade. So it really used to be this approach, an oncology approach or a cancer approach, and that's completely shifted to sexually transmitted infection, right? So HPV, human papillomavirus, is a sexually transmitted infection, the most common sexually transmitted infection. And you can imagine being told you have cancer or being told you're being screened for cancer compared to being told that you are being screened for a sexually transmitted infection. Have a huge impact on whether or not you engage in screening, how you perceive your risk for this. And so that's a pretty huge shift that we've had. So globally, when we talk about HPV and cervical cancer, the vast majority of cases occur in low and middle income countries. There's over 500,000 cases a year and about 250,000 deaths for this completely preventable cancer. And because it hits women at such a young age, it actually has a greater loss of life expectancy than AIDS, TB, or maternal mortality. So this is absolutely massive when you look on a global scale. And it continues to be the most common cancer in women in sub-Saharan Africa and in many really low resource settings. So a huge impact. Now, what about cervical cancer in Canada? So we actually have some really amazing screening programs in Canada. But when we look at cervical cancer, it's really an issue of equity because we see incredible gaps in who gets cervical cancer. And the gaps in our screening are several. One is immigrant and refugee populations in underserviced or rural geographies. Women who have either mental or physical disabilities, we see higher rates of cervical cancer, or LGBTQ plus populations as well. And what I'm going to talk about a bit more today as well in our Indigenous women, so First Nations, Métis, and Inuit women. And a study that was just fairly hot off the press that was done by the First Nations Health Authority and the BC Cancer Agency, specifically looking at First Nations women in British Columbia, showed that they have a 92% increased incidence of invasive cervical cancer than non-First Nations women. And that is quite frankly unacceptable. When we look globally, so you can see the dark red countries here are the countries that have the highest rates of cervical cancer. So some in Latin America, so Bolivia, much of sub-Saharan Africa, India, still having a huge impact globally. And again, these are places where the health infrastructure is really lacking in terms of screening, right? Because we know what works, we just might not be able to roll it out. And if you want to get me really, really riled up, get me talking about this map. So this is our HPV vaccination coverage. And if you compare it to what this map looks like, it's exactly the wrong approach. So it's excellent that we have such good, so the dark blue is national vaccination programs for HPV, but the light blue are only pilot projects, so it doesn't include the whole country. And as you can see, in much of the world, and definitely in sub-Saharan Africa, we still very much struggle to implement national vaccination programs. And these are the populations where we really need them the most. We do have a vaccination, and this is most effective prior to the onset of sexual activity, but it's also more effective in women under 26 years of age. And that's because the immune system is more robust, so you get better protection from it. So anyone older than 26, downhill, not going to lie. We also see an incredible benefit in women and men living with HIV, because they're going to be most susceptible to developing kind of morbidity from HPV-related cancers. So primary prevention is the vaccine, so we can prevent it before it even starts. Secondary prevention is when we might already be in the kind of the pre-cancer stages. And that's when, in Canada, what we use is a pap smear, pap screening, and that's how we screen for cervical cancer. And this is quite a useful graphic from when they started the screening program in the UK. So you can see this is the rate of invasive cervical cancer, and this is when they started a national screening program. And as the coverage of that screening program increased, we saw drastically dropping rates of cervical cancer. And we've seen that in many countries since. There's a few ways that we can screen, and some of them are quite invasive. The first is visual inspection with acetic acid. So acetic acid is, of course, vinegar. So you just sprinkle some, Heinz on the cervix, and the cells that are abnormal, they actually turn white. And this is how we figure out how we need to treat them. So this is the go-to in low resource settings right now, because you don't need a lot of resources. You need a nurse midwife, you need a speculum, and you need the vinegar. I've always wondered actually who discovered this? Who accidentally spilled vinegar on their cervix? I want to know. What we use in Canada is cytology. Cytology means we're looking at the cells. And that's a pap smear, so it's not a biopsy, it's not taking off a piece of tissue, it's just kind of a scraping of the cells. And this is, it has a relatively low sensitivity as a test, so quite specific. If you do have abnormal cells, it's likely to find it. But because it's not sensitive, we have to repeat it. And in BC, we do that every 3 years. The other way that we can screen, though, is we can actually test for HPV. So you can't get cervical cancer without having HPV. You can't get an abnormal pap smear without having HPV. So we test for HPV, and we tend to actually, we pick up a lot more abnormal cells. So we're able to catch things earlier. And this is really how things are shifting. We're shifting away from pap smears towards HPV testing. But we really want to talk about, so that's kind of the background of where I came to my interest, both clinically and academically in cervical cancer. So about 50% of women who are diagnosed with cervical cancer haven't participated in screening in the past 5 years. So that's Canadian data. And what we're looking at is, can we actually get women to self-collect their own specimens? Can women self-screen themselves? And in that way avoid a lot of barriers that we see to actually engaging in screening. So a pelvic exam, I've never actually met anyone who likes going for a pap smear, but some women have even more barriers to engaging and to getting a pap smear, and I'm going to touch on those a bit more later. So when we think back to those gaps in screening, the gaps where we're missing people who aren't getting screened, how can we get those women screened? As I mentioned, I'm part of a large team, a large network, and if you're going to do research that you really want to translate into health policy and to inform health systems, you really need to have involvement of organizations on many different levels within a health system and sometimes within the government as well. So I'm going to start with a project in Uganda. Sorry, I'm croaking. I promise it's not because I smoke cigars. It's just I have 3 small children at home who lovingly share their snot with me. So if you look at the incidence rates of cervical cancer in Uganda compared to Canada, there's the incidence in Canada is way lower. Women tend to have the same risk factors, but Canadian women have access to more screening. And in Uganda, it continues to be the leading cancer among women, and it accounts for 40% of all cancers in Uganda. So this is absolutely massive. And it doesn't just impact women individually, it has a huge impact on health services delivery. So in the bed occupancy, so this is like women admitted to hospital on the surgical ward, it's nearly 2/3 of the bed. So that's unreal. And the vast majority, nearly 3/4, are advanced at a very late stage. So stage 3 or stage 4 is when the cancer is already spread. Surgery doesn't work at that stage. It's really radiation that is used to treat it. And access to that, as I mentioned, in Uganda is really quite challenging. And additionally, when we look at the impact on the operating room, it's 40% of the workload. And if you think about, there's obviously services are the most important things, but in a country like Uganda, there's all sorts of other surgical needs. So there's cancers other than cervical cancers. There's a huge impact of trauma, so of like road accidents and orthopedic injuries that need. So there's huge needs that we need the operating room for again, something that we can avoid completely. But we do have innovations that we can look at. So we actually know that HPV testing detects those pre-cancer lesions better than a pap smear. So with pap smears, you actually need to have a pretty epic lab in place. So you have to collect it the right way, and it has to be processed in the right way as well. So it takes a lot of infrastructure, a lot of training. But with HPV testing, this can be done by women at home, and ideally it can be integrated into reproductive health screening. Outreach workers can be used to engage women, and the pre-cancer cells can be treated at a very local level with something called cryotherapy, which is relatively easily accessible. So where we started was it's a community in Kampala. So Kampala is the largest city in Uganda. And Kisenyi is one, has anyone seen Slumdog Millionaire? Yeah, so that's what, just imagine that, but it's in Africa. And so very, very densely populated, open sewers running through the area, quite impoverished, really low socioeconomic indicators. But because it's so densely populated, women don't have to travel far to actually get to the clinic. So most women, it would be within 10 minutes or so because they're so stacked up on each other. And you wouldn't have to travel longer than like a 30-minute walk to get to the health center. So where do you start with engaging a community? And where we started was approaching the leaders in the community to see if cervical cancer, so in general, approaching them around issues of reproductive health and seeing if cervical cancer was something that was a priority for them. And we specifically targeted women leaders in this as well. And one of the exciting parts of this project is that they weren't very hard to find. So there was lots of very engaged women leaders, and they were very open to improving reproductive health services in their community, and saw it as a very specific need. So cervical cancer, for many of us in Canada, we likely don't know someone who's had cervical cancer, and we probably don't know anyone who's died from it. Whereas that's something that is very routine for a woman in Uganda. They're very likely to know someone who's experienced it. So some of the advice we got from the community leaders was that they needed some assurance. So women needed to make sure that they, they understood how to collect it themselves. And the other thing they brought up that has come up again and again is the role of the partners. So what impact do partners have on whether or not women will participate in screening? So the next step was to actually talk to women themselves to see if they would be willing to participate. So we used, again, local research assistants who did the majority of the surveys were done in Uganda, the local language, and done in all different settings in the community. So you can see the matoke or the plantains are cooking in the background of this, this picture. And we developed a survey that we've since standardized and validated, and looked to see what factors might influence women participating in screening or not. And so really great response. So majority of women, over 80%, were willing to participate in this screening. The next process, so you've asked people, you've talked to them, and you say, hey, hypothetically, would you screen? But the next step is actually going forward and offering them the screening. And so we, based on the feedback that we got when we talked to the women, they said, hey, cervical cancer screening is great, but I also want to get screened for chlamydia and gonorrhea. Like, can you stir that in there too? Like, come on, let's make this, let's integrate things. So we did. So we offered them all of that testing, whatever, they could choose whether or not to do the testing. And we didn't have point of care HIV testing, but we did connect them to HIV testing if we offered it and if they wanted that. So again, outreach workers went around. We're at just people's houses. You say, hey, do you want to do some screening? Here's the swab. They would just go behind a curtain or go into the latrine, collect the swabs, and come on out. One of the really key parts in our feasibility program was not, participating in screening is fantastic, but you can't just screen. We actually have to make sure that women who have positive results, we can actually contact them for follow-up. That's a very critical aspect of this. And the follow-up that we did, so obviously the research assistants, they were local, they knew where the women lived, so we could do some of, track down women to some extent that way. But you don't have an address. It's not like you can look up someone on Google Maps and go 3 doors down from the open sewer, past the bucket on your left. You just can't find addresses. So the majority of follow-up was done with mobile phones. And a very high percentage of women had mobile phones. So much more, and coverage-wise, it's obviously much better than we'd get in northern British Columbia. So if you remember that, we asked women, hey, do you want to screen? 80% are for sure, I'm in. 20% are yeah, no, that sounds super weird. But when you actually offer them the swab, it was over 97%. They were hey, no, yeah, I can do that. That looks like I could definitely do that. So very high percentage of participation in screening. So that's pretty phenomenal. That's pretty close to 100%. And then as far as how many were able to receive their abnormal results and get follow-up, again, fairly high. So we really saw the feasibility project as a success, and we wanted to make sure that we were rolling it out in a way that was translatable into the current healthcare system. And some of the, there's several, an approach to really be iterative, so really to, at each step, make sure that we were responding to the needs of the community and the concerns that they had. One of the barriers that they saw to screening was some embarrassment around it. So figuring out how to collect the swab, where to put it. So we did do some qualitative work around that as well. And one of the things we found was a lot of fatalism regarding screening. So, why would we bother screening for cervical cancer? I don't know anyone who survived cervical cancer. My auntie had it, she died. My sister had it, she died. What's the point of screening? Which is, it's something that's deadly. And this really allowed us to change the way that we engaged in education as well. And one of the
kind of we got this is one of the lessons we learned along the way. So we got a knowledge translation grant from CIHR, and what the women had told us up to this point is like, it makes a difference. The influence that my friend has, that my sister has, so the idea of peer influence makes a big story. So how can we integrate those stories into education around screening and cervical cancer? And so we put together this really fantastic short video about, and it's just incorporating information about HPV and screening, but had women from Kiseni telling their stories of screening and treatment and how it worked out. And then we brought it back, so we got this input, made this video, got it back to the women, and they're like, this is crap. This is absolute crap. This is not going to work. And that was for a lot of reasons. And so we shifted completely away from that approach, and the video itself has been amazing for KT in Canada, but not at all for that in Uganda. So that was a really, really interesting thing that we learned along the way. The other thing that we had to look at was men's perceptions of screening. So the partner's influence on whether or not a woman's going to screen. So we involved 62 men in this process, and again, found some really, really interesting things. And overall, they were pretty clueless about HPV, pretty clueless about cervical cancer, but quite supportive of partner engagement in screening, and even more supportive of having their daughters vaccinated for HPV. We also wanted to look specifically at women living with HIV. So women living with HIV, it's about 10% of our population in Kiseni. They're more likely to have faster progression with cervical cancer because of the impact on their immune system. But they're also more likely to get high-risk types of HPV to start with, and have to have more than one type at the same time. So we consider them quite high risk. So we did this in two parts. We both did some surveys looking at not only their kind of intention to engage in screening, but also, again, the impact that the HIV would have on how they perceive their risk. And the second part was to actually offer them a screening in the setting, integrated into the HIV care that they were already accessing. And we got some pretty incredible results from that process as well. Now, we've done a lot at this stage. So we asked a lot of individual questions. We've done a feasibility study. We knew it worked. But again, going back to the influence that your research is going to have on health policy, and what kind of recommendations there are at whether it's the health region level, national level, or globally. There was actually a specific call from the WHO for randomized controlled trials, looking at what the optimal approaches are for cervical cancer screening in low resource settings. We said, hey, we've got all this infrastructure, let's roll this out. And unfortunately, academia in general is a bit obsessed with RCTs, and there's certainly plenty of critique as an approach. But what we wanted to do was a pragmatic randomized control trial. And pragmatic means that this is not, we're not interested in the findings in the ideal research settings. We're interested in what the findings are in the real world. And that's why we used a pragmatic approach. And if anybody's interested in that specifically, I'm happy to provide you with some references around that. So we took 500 women and randomized them either to HPV self-collection or to VIA. So that's the visual inspection with acetic acid that's done at the local health clinic. That's the vinegar one. We recruited all the women in the same way. So again, our health workers were out just in the community and talking to women. And the follow-up we did was again with mobile phones. And if women had a positive HPV test, then they would need a pelvic exam, and treatment would be offered at the same time, again at that local clinic. And so we recruited 500 women, randomized to the two arms,
And this is the HPV arm. We saw 92% uptake in screening. 92%. So that's, or sorry, 99%. That's fairly close to 100. I'm not a gynecologist, they're pretty simple folks, that's why I have to clarify that. And then when we looked at the VIA arm, so this is the one where they had to go to the clinic, which isn't too far away, and a nurse midwife would do this pelvic exam. We had less than 50% of women participate. So incredible barriers. Even though the clinic is closed, the service is available. It's available. We have trained, we made sure the infrastructure was in place with trained midwives, the equipment that was needed. And what that means, when less women engage in screening, we were less able to actually detect the precancerous lesions, and less women get treated overall. So one of the really important things is what are the drivers of this really high uptake for self-collection? And some of the lessons that we learned from this, again, this urban setting, were that it was so important that this was a women-led intervention. So we had, women on board from the beginning. Sorry, and there was a strong social cohesion in this community. So women identified themselves as women from Kisenyi, regardless of where they'd been born. They were women from Kisenyi. They knew who their leaders were, and they very quickly kind of identified themselves with the project. So we're women from Kisenyi, and we participate in screening. That's what we do. And the other critical part to this was we weren't screening for something that was this pie in the sky disease they hadn't really heard of. This was a cancer that was all too close to them, that they've seen a huge impact on each other's lives. And so I think that those are some of the reasons why we had such an incredibly high uptake. And the success of these projects in Uganda has really led us back to British Columbia to say, hey, if we can offer this in such a low resource setting, how can we then, how can we use this tool not to replace current screening? So, we're not interested in women in BC who actually participate in screening. That's great. They're getting screened. We're going to prevent their cancers. But we really want to figure out how in this high resource setting, this high income country, we can target women who are not getting screened. So we've developed a pilot project called Cervical Check, and it enables women who are under screened, so they haven't had a pap smear within the past 3 years, to actually self-collect a specimen. And so with Cervical Check North, we're partnered with Cervical Family Services and also Métis Nation BC. So Tanya Davrin, who is the Director of Health for Métis Nation, and Terry Aldred, who is a physician with Cervical Family Services, are the leads. The other pilot project we're doing is in the Fraser Valley. So the uptake of PAP in the Fraser Health region is one of the lowest in the province. And part of that is the immigrant population that we see. So Cervical Check Fraser is focusing specifically on immigrant populations. So when we talk about the barriers to screening for Indigenous women, so when we talk about screening for any woman, it is an invasive exam, so it's a pelvic exam, and it's arguably uncomfortable, and there can always be embarrassment associated with that. When we talk about rural and remote geographies, it's actually hard to find providers who do this, to schedule an appointment. You actually have to get to your appointment. You may or may not be able to have your 3 children in the room while you're getting a pap smear as well. There's lots of barriers just due to the geography. But if you have an auntie or a grandma who was sterilized as part of previous interactions with the healthcare system, if our colonial healthcare system has given you no reason to trust them in what they're recommending, if you're concerned about confidentiality when you go in to get tested, because your sister-in-law is actually the receptionist at the clinic, excuse me, if you're concerned that there's not a female care provider who can do your pap smear, you have infinitely more barriers to engaging in that screening. And that's part of the, these are just kind of a taste of the types of barriers that Indigenous women in Northern BC face when thinking about doing screening. And I mentioned previously that drastically higher rate of cervical cancer that we see among Indigenous women. So how can we actually put the control back in the hands of women? How can we provide an option so they decide where they do the screening, they decide when they do the screening, and avoid that invasive pelvic exam? And that's what we're looking at. So this is some of the material that we're developing for Cervical Check North. Again, we've talked a bit about the rural barriers simply due to geography. Again, layered on top of that, the impact of the fact that we do have a colonial health system, and we don't always provide culturally safe care, and we certainly don't always provide trauma-informed care within our system. So what the project does is it offers self-collection kits that can be collected at home, and they're basically mailed back via analyze. I'm really sorry. Blame my children. So we're looking at two different models. And this is in discussion again with Métis Nation and with Carrie Sekani. So Carrie Sekani has 11 different communities. Some of them are quite small, quite isolated, whereas Métis women in northern BC is a very different distribution, slightly more urban. There are chartered Métis communities as well, but overall we would say they're a bit less geographically isolated. So we're looking at different approaches to engaging with different populations. So the first model is an online model. So when we get the invitations through several different approaches, they then log on to the website and create an account with their information and their primary care provider, and then they're mailed out a screening kit. They get the kit, so it doesn't say like cervix check on the front of it or like HPV. It's very like bland. It just has their address on it. They do the self-collection. The kit's designed in a way that's very easy to use. It doesn't look intimidating. Like you open it up and it's like, hello, thanks for taking care of your health. Like really positive imaging, very easy to use. The self-collection's done. The kit is mailed back, so it's already, the postage is already on it. They're designed to make sure they fit in it can be mailed just as a letter. And then they log in again to get the results. If they're negative, they're told they're negative and what the recommendations are. If they're positive, they get, it just says, it basically doesn't tell them specifically what's positive, it just makes sure that they're connected to the primary care provider that will be able to review those results with them. The other model for uptake is community-based. And it's really interesting to see the feedback we've been getting from communities on which they prefer. And for a lot of reasons, including the ability or not to access a confidential place to use the internet. The other model that we're looking at is very much more just at the level of a community health center. So again, women get an invitation to participate. They can drop by the community health center to pick up the kit. They can choose either to collect it themselves at the clinic and leave it there, or they can take it home and collect it whenever they have time and drop it off at the clinic afterwards. All the kits are mailed by the clinic, and then follow-up is done with the care provider at the clinic. But with the idea that both of these options are not only enabling women to have a more confidential option for screening, definitely to avoid the need of that initial pelvic examination. But the bigger issue is to actually have control over where and when and how they're actually screening themselves. So the next steps that we are looking at and what we're aware of at each stage of this project is ensuring that the way that we're designing it actually fits within our current health system. So we don't want to have to pour in a whole bunch of extra resources to make sure that we can still have this as an effective program. So because of that, we're making sure that we're informing what a larger project might look like, either on a health region level or what it might look like provincially. We're also doing other ongoing studies in Uganda. So Kisenyi was really urban, so really densely populated, but much of the population still continues to be rural in Uganda. So we're working in a district called Mayuge in Uganda, which is a rural area, but comparing 3 different models for engaging women and finding out, again, not only how are they going to get screened most effectively, but how are we going to enable that complete follow-up, so they're actually going to get treated as well for those precancerous findings. So we're very interested in how are we going to target more rural populations. And we're also looking at HPV self-collection in other cultural, kind of different cultural areas. And we're partnered with the University of Michigan for some projects right now in Guatemala as well, again with a focus on Indigenous women. A lot of different areas going forward as well. So obviously I'm a women's health researcher, and I'm also a women's health physician. And so I do really believe that improving women's health is critical to improving the health of families, to improving the health of communities and beyond as well. And I really love this picture. So in the front in the white shirt is Veronica, and she was one of the village chairpersons in Kisenyi, just a really inspiring women. But you can see just the looks on their faces, and they're talking about self-collecting the swab. And even though these women in Kisenyi, again, they live in this impoverished neighborhood in Uganda, and when you hear them, the jokes that they make about vaginas and screening, and then you go out to like Sycus or Nadley, with different Karisakani communities, and you hear the same jokes from women, and it's really phenomenal. I find it so fascinating because they are literally worlds apart in terms of not only geography, but history and culture and all of those things. But regardless of that, every woman deserves the chance to be screened effectively and not to have cervical cancer. So that's the end of the talk. I'm happy to take any questions, or if you'd rather email me, that's fine as well. You can follow me on Twitter. I tweet about 50 Shades of HPV, also colonialism, stuff like that.
Well, I think, Sheona, you've got there's some of the students here are taking a health research methods class, and there was an amazing, fabulous array of health research methods in there, as well as the kind of grounded aspects of all the communities you've worked in. So I really am hoping there will be some questions. This is a time to just try to figure out, what you've been learning in theory and reading in your textbook. You've got a real live RCT researcher here, but you've also got somebody who can talk about RCTs and all sorts of other kind of research methods and recognize that they all have their strengths and weaknesses. So any questions for Sheona as this is a good chance? Yes, go ahead.
So we're doing it a few different ways. And again, we're very much just in the kind of ramping up stages of this project. And for the Métis Nation women, the recruitment is mostly on social media, and it's really neat. So they have a lot of like online communities as well. So it's using those. It's using some existing networks that they have in terms of how they let women know about different, health services as well. But it's very much kind of the focus really is kind of a social media approach, but targeted at kind of specific communities in northern BC. And again, they're the ones that they'll be, and it's quite easy to do because it's an online program as well. So we do have, we are doing community meetings as well, and sessions where women can come and talk about things, but, and ask questions about the project. But the big piece is really just the online options, and then it's literally clicks to the website to register to get your kit. So trying to, make it as easy as possible for women to participate. And then for the Carrie Sicani community, they have, so each community is quite different, but they have health fairs from time to time. So we're, people are becoming aware of this option through those opportunities. They're like community events. But what the women asked for was just a really easy to read flyer that everyone gets. So, delivered, to everyone in the community as well. So quite different requests that we had from different types of communities. So.
Oh, great. Two questions at the back. We'll start with the person on the right, closest to the light that's shining at me. So that's you.
Yeah, thank you. I was just wondering about your work in Uganda and more about the confidentiality of the women, and if there was ever any danger of them disclosing any of their reproductive health factors to you, or if any of the women were ever in any danger, I guess, and how you handle the confidentiality.
Yeah, so it was pretty interesting because sometimes the places that we even did the surveys were out, and they were at the stall selling food by the street, right? And so I think the reason why that approach worked in a setting where there's really minimal access to privacy is that it is the women who are doing our actual research assistants. So women like Veronica, they'd be sitting down. She was amazing to watch. So she'd be sitting down and amazing rapport that she builds with these women. And part of the ethical process is ensuring that these results are confidential. And that was a lot of the training we did with the research assistants as well. So going through asking these questions, and a lot of personal questions about, sexual partners and pregnancies and all this stuff. And someone would just stroll up and stand close by, and she'd just turn around and be like, yeah, what's happening? Yeah, no, move on. And then she'd get on with it. So I think that again, it was the reason why we could do it effectively was because of the ownership that the research assistants had, and that this was their project. They were really proud of it. And because of that, they, followed the the letters of the law in the, what was required confidentiality wise. And women who were worried about that didn't have to participate, right? So again, it's there was this option, but it was never, obviously coercive or anything like that. As far as the women living with HIV, part of the reason why we did that at the clinic and not in the community was partly because of those confidentiality issues. So these are women that are already coming to the clinic for their HIV care. So things are set up in a way to facilitate their confidentiality. But yeah, that's something that has to be maintained, obviously.
So we'll go to the next person here. I'm just going to let the people online know that I'm going to shuffle over to the screen here and pull up the blue jeans in case there's a question from online. But there was another question up in the back, and I'll just switch places with you here.
So it's just, apologies to talk about this. Talk about your two service effects programs and their focus on certain populations. So you already mentioned quite a few other populations of women who are at increased risk. So are those programs offered to all, and you're just hoping to, target your advertisement more towards the populations, or are they going to be offered to the Indigenous population or immigrant population? Like, what if a friend were to speak to, like a girlfriend of hers about it who was like a low income, non-Indigenous woman, would she have an opportunity to partake in the program as well?
No way, no white people. Forget it, white people. You're out. No, so this is it's definitely a challenge, right? Because we don't want to be exclusionary. And so we're actually not just providing a health service. We are actually also doing research. And so so when you look at program evaluation, that's actually quite different from setting up a research study. And so if we were purely doing a program evaluation, we could just set up the program, and whoever was eligible, and they participate, that's great, it doesn't really matter. But what we have to do is you have to define, what is your inclusion criteria? And so partly because of the importance of follow-up, we have to know what provider is going to be responsible for that. And that's one of the reasons why when we're starting looking at these programs, we kind of have to start small with a defined population. And so for the Carriage to Canny women who are participating, they actually have to get their care from Carriage to Canny. So even if you're you live part of the time in one of the Carriage to Canny communities, but your GP actually they're in Prince George or they're in Vanderhoof, we just can't ensure that all the information is going to get to them. And so for ethical reasons, you have to make sure that you're providing that follow-up, right? So you screen for them, you have positive screening tests, they're highly likely that they're going to have a precancer that needs treated, but they don't have follow-up. That's a serious ethical problem. And so that's part of the reason with this approach that you have to start small. I think, if and when it gets scaled to, for example, to the Northern Health region, it's going to look different, right? But no, that's a really good question. And similarly with the Cervix Check Fraser, it's even starting out with very specific clinics who are participating as well. So those are some of the reasons.
Thank you.
Just kind of picking up on the question around confidentiality, I'm curious, you sort of mentioned at the beginning that the kind of conversation around cervical cancer has shifted from cervical cancer screening towards STI testing, and whether or not the stigma around STIs, do you feel like that is a barrier to people getting HPV testing?
So that's a really good question. So we've done, and we've done quite a bit of work around this, kind of like the larger HPV research globally, and it really kind of changes the perceived risk, and a key part of that has been kind of normalizing HPV. So in the past, all women get screened for cervical cancer, that's just how it works. And now it's but it's an STI, I'm not at risk for cervical cancer. And so a big part of that has been really kind of normalizing HPV. So about 80% of men and women will get HPV at some point in their life. 80%. Not 10%, not 20%, 80%. So really we consider it ubiquitous. So that's why we screen everyone who's sexually active. So it has meant a real change in the discussion around that. And it has certainly, I think it's had a less of an impact on screening and more of an impact on vaccine uptake. So one of the concerns that parents have when they're consenting, so in British Columbia, boys and girls get vaccinated in grade 6 for HPV, but they do have to have parental consent. One of the concerns that parents have is little Daisy, she's actually never going to become sexually active, so she doesn't need this vaccine. Or they'll say, hey, why can't Daisy decide when she's 18? It's her choice. She's going to know more about it. And so I think that discussion has come up more then. And the more important, I mentioned it in the presentation, but yes, it's important to get the HPV vaccine before you're sexually active, so before you're exposed to any HPV. But you actually have the grade 6 it's not just because we hope it's before they're starting to be sexually active. It's actually because they have a better immune response. Mm-hmm. So they're actually going to be protected better and for longer. And I think that's one of the more effective ways to discuss it with parents. But it is, it certainly changed. But I would say the impact has been less on the screening side and the perceived risk, and much more on vaccine uptake, definitely in Canadian or in kind of industrialized countries. Yeah. if that answers your question.
I have a related question, and then we've got one from Sarah here. So there are some really interesting dynamics, and I don't know here, but I know in New Zealand, because of my sister's a family doctor, and there's this interesting dynamic about the vaccine being something that you have to pay for, and that because it's not actually part of the system. So then you get into this very interesting thing of, am I going to pay for a vaccine if dear little Daisy's never going to be sexually active or isn't sexually active yet, and decide somewhere along the line this disconnect between wanting to have the vaccine when you're at the most effective age and pricing issues and questions of whether it's actually part of sort of a public health package, or whether it's actually a volunteer thing. Mm-hmm. And I'm curious about your sense of that in terms of, that would be most relevant in Canada, I imagine, but that there is also that possible potential for vaccination in Africa and Uganda, in these particular places, but you've been focusing mostly on screening for the virus, or the presence of the virus, as compared to imagining vaccination. I'm just kind of wondering about, in terms of the broader area of your research, where that kind of screening vaccination piece lies and where it might unfold as your work kind of carries on, and the question of whether vaccines are paid for or not, which is always such a tricky public health question.
Yeah, no, it's a really good question. So, kind of on a global scale, so as far, we've also done work in South Africa, so in Durban, and the focus of the work there has been around the HPV vaccine, and looking at a youth cohort with that. And one of there's an organization called Gavi, GAVI, and they basically subsidize the cost of vaccines in low resource settings. So much of sub-Saharan African countries they're Gavi eligible, and so they negotiate for kind of a lower price per dose of vaccine. And so, I mean, that has a big impact on whether countries kind of can afford these national programs. And so they don't just do it for the HPV vaccine, obviously they do it for like the rotavirus vaccine and measles and all of those things. So that impacts on, globally in low resource settings. And certainly, that even when that funding is available, countries don't always take advantage of it as well. In Canada specifically, the HPV vaccination is covered in school-age kids. And so in British Columbia, it's covered up to age 26. Right. I don't know if there's anyone under age 26 here, but I'm just saying, it's a little bit sexy. But definitely like school age, it's totally covered. And so that, even though it's completely covered, we still are only up to like 70% coverage. So we still have a long way to go. So there's still lots of barriers to getting vaccinated.
And would you say that the barriers there are about notions of, I only need the vaccine if I'm going to be sexually active? Is that the block, or is it?
There's also just like an anti-vaccine crew that thinks that public health experts are just out to make a buck, and they're in bed with the pharmaceutical companies. So the HPV vaccine, it is the most expensive vaccine to ever be developed. Wait, I don't know how the Ebola vaccine, maybe that's more, I don't know. They're not really selling that over the counter. So it's really expensive. And so you could understand, when the province of BC makes a deal with a pharmaceutical company to buy the vaccine, you can understand why people might be, wonder about what the evidence is to actually use it. So I think there's overall just like the kind of like anti-vaxxer, to use a completely made up term. That kind of movement is probably the greater barrier. And it's really interesting, some studies in BC that we've done on, so specifically looking at parents and their intentions to vaccinate and why they do or don't vaccinate. The parents who are least likely to vaccinate are white, highly educated, higher income families. So it's really interesting. And I think one of the areas where we have a lot to learn from First Nations communities is we actually see much higher rates of vaccine uptake in a lot of First Nations communities than we do in the rest of the population. So yeah, we still have a lot of work to do with the vaccine.
Yeah. The question from Sarah.
Yeah, it's just because, so I recently moved back to BC, and so I'm too old to have gotten it, and I'm 36. And so when I saw my new doctor, when she gave me prescriptions, I felt like she must have kind of a reminder, like and so I was just wondering about the vaccine. One question I had that the pharmacist couldn't answer was sort of like, well, what if you already had HPV, like you already had some kind of form of HPV? It sounds like it's different strain, and you got the vaccine. What happens? Like, is it still beneficial, or is it just for new infection?
Yeah. Yeah. So the vaccine we're using now is a non-covalent vaccine, so it covers for 9 different types of HPV. We've what we found with the vaccine that's really interesting. So obviously it would protect women from types of HPV that they haven't yet been exposed to, which is fantastic. But we've also found about like a 40% increase in clearance of any current HPV infection, and even some reversal in the abnormal cells in the cervix. So there's been kind of immune benefits that we didn't actually predict. So the non-covalent vaccine is it's approved up to age 45 for women. And so there's still benefit up to age 45. The largest benefit is no question the younger you are. And in fact, in school you only need 2 doses. And then once you're over age 16, then you need 3 doses. But there's definitely still benefit to it. Absolutely, yeah.
I flicked back through the slides, but I don't know which one I'm looking for.
Oh, I just read it anyway, because lots of times I have to talk a lot about the vaccine. Everyone has lots of questions about it, which is great. But I don't know if I had a specific line. Anyway, yeah, I think I answered your question though. So it's basically like the vaccine. It's really effective. It's really safe, and everyone should get it. That's a take-home message.
Free message from you.
Yeah.
So we've got time for some other questions. Does anybody else have any queries about the research or the studies or the doing international research across different cultures? I have a question because I think at a health research seminar series we're allowed to talk about anatomy. So can you tell us what does the self-testing involve?
Oh, for sure, yeah.
Because I think it's a really interesting thing. This is it's an important aspect of this study, but it also does often for people. It's kind of like
I don't have a great picture. Sorry.
Oh, that's okay.
Yeah, it's a really good question. So here's the.
You took a good picture early on.
I did
with the old school cap.
No, that's actually standard of care, Rachel. There we go. Yeah. Okay. So anyway, so this is one of the problems we have with like health education is like this is like a really terrifying image of this like metal thing going, like it's just horrible. So with a pap smear, so the reason why the cervix is vulnerable to HPV, so you can get HPV infections other places. HPV causes like low risk types of HPV also cause genital warts. HPV causes like penile cancers, vulvar cancers, anal cancers as well. But the reason why the cervix is so sensitive to it is that it transitions between 2 different types of cells. And so there's a different type of cell in the endocervical canal, so inside the cervix, than there is on the outside of the cervix. And when you do a pap smear, you have to get that transition. So that's why you have to do a pap right at the cervix. It's really important. You can't do a pap if it's not right at that, what we call the transition zone, it's not a pap. Like you have to get that transition zone because that's where the abnormal cells are going to come. The way, because of how the cells change, they're very vulnerable to the HPV infection. And that's why we need to do a pap right there. HPV though is a virus and it's just present. It's present in the cervix, but it's present in the vagina as well. And so although we're specifically looking at cells when we do a pap smear, when we do an HPV test, the current tests are PCR. So it's looking at the DNA. So it's an HPV DNA test. So because of that, if you get close to the cervix, and certainly physician-collected specimens that we do for HPV compared to self-collection specimens, they are more accurate, but there's about a 90% crossover. So that's pretty good. So usually so this is obviously the speculative, scary, terrible. With the self-collected swab, it's a swab that looks like it just looks like a Q-tip. So that type of swab, so that's how large it is. And it just has to be inserted less than 10 centimeters, so a few centimeters into the vagina, and it's twisted and removed, and that's it. So it's so anatomically, it's much less invasive. It's not as, it's like putting a Q-tip in the vagina, so it's would very rarely be kind of uncomfortable compared to having a speculum exam. Does that answer your question?
Yeah, it does. It's
Yeah,
really helpful.
okay.
And I think it's just to differentiate between it. Now, Maddie's got another question.
Lots of questions. And to follow up on that, you mentioned that the cells taken in the pap smear have to be processed at a fairly high, like specialized lab. Can the swab be processed at places with sort of less resources for it?
So this is
I don't know the words to use.
Yeah, so this is the difference between screening in a really a high resource setting like British Columbia compared to low resource settings. So there's a platform called CareHPV that has been developed specifically for low resource settings. So it's actually it's fairly small. It's about this size. It tests for 14 different types of high risk HPV. It can actually be run without electricity and without water, so it can run off of a battery. And so and specifically was developed. So it was developed by PATH. It's a pretty amazing organization. You guys should look them up. And so the technology is certainly there for low resource settings. And it's available at relatively low cost per test, right? And that's exactly what we need. So they developed it for low resource settings, but then they found out that it's actually an awesome test, and it would actually be good enough. Like, we would use it in BC if we could, but the problem is that companies can't make money off of the fancier tests if this one was all that we used, right? In BC we're not, so it's only licensed for low resource settings. This is why the world is so messed up, people. And so that's obviously an excellent resource that we have, and we use it in our kind of low resource settings where we work. But in BC, it's a relatively more expensive test, and it's something that's done at BC CBC. So the tests are actually run in Vancouver, but it's fairly easy just to mail specimens down. So there's actually lots of tests that are done in BC that are centralized in Vancouver. So any of our HIV testing, lots of different things that involve infectious diseases are actually all shipped down to Vancouver as well. So yeah. Yeah.
Well, thank you very much, Sheona. There's a lot of things to like about this presentation as I sort of wrap up one for the semester, and including the fact that the high level of personal relevance for 90% of the people in the room, but for the fact that this is also, and I really appreciated in your talk that you really pointed out how important it is for men to be part of understanding. Just as it's important for women to understand prostate cancer, it's also really important for men to understand cervical cancer and other cancers that are distinct to women, breast cancer being relevant for both men and women. So there's something really important about that personal connection with a talk like today, but also a really neat example of how some of the determinants of health stuff that you've been learning about are really relevant, especially in terms of equity issues that are underpinning, no matter how fancy your research is, what actually may be able to be implemented or not. But probably one of my favorite bits of the stories were actually when you were pointing out that despite the odds in places that can be considered underprivileged or marginalized or less able to be able to respond to some of these things, you were able to really point out how those communities have real assets and in some ways are ahead of the game in terms of where other places are and how we might think of people being able to implement change once they get the relevant knowledge and information. So some really neat themes. I want everybody to give Sheona a really big show of appreciation. So as we said earlier, we're always open to
suggestions, please don't hold back. Please come to the AGM if you're around in April, still, to those of you that are here, or send Rachel any suggestions for future sessions. And also, if you have any thoughts as you're leaving Sarah's class about things that you might think would be good, Sarah might be able to sort of collect some feedback if you think there are pieces that you think would be good for us to know when we're doing this in the future. We'd be really happy to hear them. So thanks everyone for being here. Thanks Sheona for finishing, and Rachel. I do also want to acknowledge that our colleague Sarah Gray, who was supposed to be hosting you today, from the NMP, wasn't able to be here. But she will say a big thank you so much. Yeah, thanks everyone. Thanks people online. Bye. We did have some people online, so that's cool.